Okay, so welcome everyone. Welcome to this third day of this abdomen and pelvis week, and we are into this most comprehensive MCQ series on anatomy. I'm Doctor Ankit, and you are into the channel named Human Anatomy by Doctor Ankit. Let's start the MCQ of the day. So first MCQ of the day is a 67-year-old lady comes to the physician because of 5-day history of episodic abdominal pain, nausea, and vomiting. 5-day history. Pain and vomiting. She has a coronary artery disease, CAD, and type 2 DM. She takes aspirin, metoprolol, and metformin. So she is taking aspirin, also a beta blocker, and a metformin, bicarbonate. She is 5'4" tall and weighs around 91 kgs. Her BMI is 34. BMI is on the higher side, obviously. Temperature is 100.6. Fair enough. All the findings. The physical examination shows a dry mucous membrane, abdominal distension, and hyperactive bowel sounds. Ultrasound of the abdomen shows air in the biliary tract. This patient's symptoms are most likely caused by obstruction at which of the following location? Beautiful question. Let me tell you, the sort of similar question was recently asked in NEET PG or INI-CT. Now look at the patient over here. This patient has so many of comorbid conditions. 67-year-old female having the artery disease, having the type 2 DM, and taking all those drugs, is obviously overweight, or you can say on the obese side only, and episodic abdominal pain, nausea, and vomiting. So there is some problem in the abdomen. That is why we have placed a question under the abdomen part, right? Now, temperature is slightly on the higher side. Dry mucous membrane, abdominal distension, hyperactive bowel sounds. Hyperactive bowel sounds tells you what? That there is some intestinal obstruction happening over there, as abdominal distension as well. Ultrasound shows air in the biliary tract. That is very abnormal finding, you can say, and that is what is known as pneumobilia. That is also known as pneumobilia. Normally you don't see air in the biliary tract. Now the patient's symptoms are most likely caused by obstruction. So they are saying two main findings. One is there is some intestinal obstruction is going on, hyperactive bowel sounds, abdominal distension, pain, nausea, vomiting. That is typical features of intestinal obstruction. Second thing is there is air in the biliary tract. Where is the obstruction? So what actually happens is, here we have to understand the anatomical relationship of the biliary tract to the gut. So where does, if I ask you, where does CBD finally open? You will say that CBD opens into the second part of duodenum. It's absolutely correct. Imagine this is the second part duodenum and the CBD is opening over there. Now it might have happened that the CBD over here might have some stones. That stone could have entered into the duodenum, but there are walls. So we can also imagine, as you have seen, that there is also one important organ over here which is related to the duodenum that can have stones, that is the gallbladder. So what actually can happen, that the gallbladder itself is related to the first or second part of duodenum, and this gallbladder might have stones, and due to the rupture of the gallbladder or perforation by the stone from the gallbladder might have entered into duodenum. This would give us two things. One is that a stone has entered into the duodenum. So a stone has entered where? A stone has entered into the gut. That might lead to obstruction, point number one. So second thing, when there is a channel, continuous channel between the gallbladder and the gut, now gut has air, we all know. Air could have entered into the biliary system. Air could have entered into the biliary system, showing us the pneumobilia, air in the biliary tract. So this thing will tell us that. I mean, this is the only possible explanation right now. Okay. So now, where is obstruction? So now, if the stone has entered into duodenum, it will pass through duodenum and jejunum. Then it will pass through jejunum and ileum. What happens at the distal ileum? We have an ileocecal junction, which has ileocecal wall. There it could have an obstruction. Answer will be distal ileum over here. This is the area where there can be obstruction, because there you have walls. It is one of the most constricted part of the gut. Answer will be distal ileum. In a case of pneumobilia, pneumo means air, right? So the two findings over here, I hope you got the point, right? Fair enough. Next question. A 50-year-old man is brought to the emergency because of severe abdominal pain for the past 2 hours, 2-hour pain. He has 2-year history of burning epigastric pain that gets worse with meals, Probably it's more pointing towards, possibly towards gastric ulcer. We'll keep it as our diagnosis. His pulse is 120. Respiration is 22 and BP is 65. BP is very going down, 60/40. Despite appropriate life-saving measures, he dies. Sorry to hear that. At autopsy, examination shows erosion of the right gastric artery. Point out towards the gastric ulcer, right? Perforation of an ulcer in which of the following location most likely caused this patient finding? So, erosion happened in the region of right-sided gastric artery, and that actually perforated, and that led to so much of bleeding in just 2 hours, BP going down, and patient was unable to live. It could not be saved. Now they're asking you perforation of ulcer in which of the following locations. So they're asking basically that do you have any idea where is this right gastric artery? In the stomach. So if you look at the stomach over here, let me show you an image over here. This is an image of the stomach having this lesser curvature, okay, and this being the greater curvature, and these are the various important vessels. This is the right gastric, that is the left gastric. Both are towards the lesser curvature of stomach. The gastroepiploic vessels, these right and left gastroepiploic vessels, let me use a different color, more soothing. Right and left gastroepiploic vessels, these are found at the lesser or at the greater curvature. So this right gastric artery which is asking you will be lying at the lesser curvature. Do you have the options over there? Here we have option number E, last option. Right, it was the case of gastric ulcer, and the right and left gastric artery are towards the lesser curvature. Remember that. Okay. 65-year-old lady comes with the AF, atrial fibrillation, comes to the emergency because of sudden onset severe abdominal pain, nausea and vomiting for the, again, 2 hours pain. She has smoked a pack of cigarettes daily for the past 25 years, 1 pack of cigarette, okay. Her pulse is 110 and BP is 140 by 100 on the higher side. Abdominal examination shows diffuse abdominal tenderness without guarding. So there is abdominal tenderness. 2-hour history of what pain and all, atrial fibrillation, fair enough. Without guarding or rebound, a CT angio abdomen confirms an acute occlusion of the IMA. So again, all this history with the atrial fibrillation, emboli might have gone, and increased BP, smoking history, emboli could have occluded into the origin of the inferior mesenteric artery. We should knowing that if this is the abdominal aorta, we have celiac trunk, superior and inferior mesenteric. This is celiac trunk, superior mesenteric and inferior mesenteric artery. The 3 arteries of fore, mid and hindgut. So emboli might have obstructed at the inferior mesenteric artery over here, right? Acute occlusion, that is obviously given rise to the abdominal ischemia. Which of the following structures of the GIT is most likely to be affected? Now this IMA supplies what part of the gut? It is hindgut. Do you know what is hindgut? Hindgut is from the distal 1/3 of transverse colon, then going down to descending colon, then going down to where? Sigmoid colon, then going down to where? What comes after colon? We have the rectum, and basically then goes down to the anal, but anal canal will have its own arteries from the perineum part, basically the internal parental arteries. So this area is hindgut. Now they are saying which structure now? Rectosigmoid colon over here. Rectosigmoid colon is this area. Will it be affected? Obviously yes. So actually we should also be knowing that this inferior mesenteric artery gives of 3 main branches. What are those 3 main branches? Are one is the left colic artery, which supplies actually this area. Let me write over here L dot colic artery. Then there is sigmoid artery supplying the sigmoid colon area, sigmoid artery, and then there is superior rectal artery. This area is supplied by the superior rectal artery. These are the 3 major branches, 1, 2 and 3. Answer will be rectosigmoid. Let us see other options to rule them out. Terminoileum, midgut. I am writing M over here. Hepatic flexure, midgut. Lower rectum will have inferior rectal artery or middle rectal. They are coming from the internal iliac branches. So it is below. You can write pelvis or perineum. Ascending colon, midgut. Therefore, answer is this. Now here in this image, try to show you the inferior mesenteric artery, and with their 3 branches, left colic, sigmoid and superior rectal. I am not sure how very well you can see, but you can understand that this whole area from distal part of the transverse colon to descending to sigmoid to rectum, this is our hindgut. This is our hindgut, and this is the superior mesenteric artery giving off supply to the midgut area, right? Fair enough. Let's see the next one. A 33-year-old lady comes to the emergency because of 1 hour history of severe pelvic pain and nausea. Okay, now pelvic pain in a young female. She was diagnosed with a follicular cyst in the left ovary 3 months ago. That's quite normal. Cyst was found incidentally during a fertility evaluation. A pelvic ultrasound and Doppler flow shows an enlarged edematous left ovary with no blood flow. Now there's some obstruction to the artery. This is enlarged ovary with no blood flow. Lab evaluation shows necrosis of the left ovary and left oophorectomy is performed. Now the organ has died. During the procedure, which procedure? Left oophorectomy. Blunt dissection of the left infundibulopelvic ligament is performed. Left infundibulopelvic ligament actually is nothing but it is a suspensory ligament by which the ovaries are suspended from the pelvic wall. The main content of this infundibulopelvic ligament will be the ovarian vessels, will be basically the ovarian vessels. And remember, the ovarian artery is coming from abdominal aorta. So now, blunt dissection of this ligament was performed. Which structure is most at risk of injury during the step of the surgery? Now, during dissection of the infundibulopelvic ligament, which structure is close to it anatomically is the question. That is why this question is in the anatomy part. Ureter is the perfect answer over here. Ureter. Ureter comes from behind and then it goes anteriorly, entering to the bladder. It is very close to the ovarian fossa, very close to the infundibulopelvic ligament. It is at risk. Other options, bladder trigone is more anteriorly. Uterosacral ligament. The uterosacral ligament is more inferiorly located. Right? It is more inferiorly because it is nearly the cervix area. It is one of the supports of the uterus that goes behind. It lies more in close association with the mesorectum. And kidney, obviously kidney is quite high up. So answer over here is ureter, and let me show you an image over here as well. This you can see the ureter over here, that you can see the ovaries, and these are the suspensory ligaments. Now you might be thinking, sir, oh, ureter is over here. See, ureter is coming from where? From the kidney. So kidneys are retro and ureter is retro. So ureter is more posteriorly, then it comes from posterior to anterior as it enters into the pelvis, being very close to the ovarian fossa, near the bifurcation of the common iliac artery. Remember, that's the location of the ureter. Okay, let's see one more question over here. A 40-year-old lady comes to a physician of 2-week history of anal pain that occurs during defecation and lasts for several hours. Some problem in the anal canal, what we can see from the first line. She reports that she often strains during defecation, so has a history of constipation, and sees bright red blood on toilet paper after wiping. So she is using toilet paper, she is having some constipation issue. She typically has 3 bowel movements per week. Now see, don't go with the 3 bowel movements. It is exactly a case of constipation. Constipation is defined when there is irregularity in a normal, whatever the normal rhythm is there. 3 times per week could be normal in some areas of the world. Okay, so don't go exactly the numbers. It is definition of diarrhea constipation is more of the consistency or the texture of the bowel which is coming out. Physical examination shows a longitudinal perianal tear. This patient's symptoms are most likely caused by tissue injury in which location? So, it's bright red blood they are seeing, it's sort of constipation, bowel movement, and 2-week history of anal pain, which occurs during defecation, and after a couple of hours it goes away. And there's a tear, so obviously it's a fissure, it's an anal fissure over here. And the most common location of anal fissure is where it is posteriorly in the midline. That's the most common location. Because of decreased blood flow over there, that area, it could develop fissure. And as it is painful, will it be distal to pectinate line or will it be proximal to pectinate line? It will be distal. Why? Because the distal part of the pectinate line that is coming from the proctodeum, it is ectoderm, and it is having pain sensitive nerve endings. So pain is normally felt when it is distal to pectinate line. So the options which are saying proximal to pectinate line, we can remove then B and D. What are left with AC and E? Posterior midline, yes, posterior midline would be the answer, distal to base. Anterior midline, not a common location. Lateral aspect, not a common location. The most common location is posterior midline, distal to pectinate line because of the history of pain, right? Here you can see the image showing us the anal fissure over here in the posterior midline area, right? So guys, that was all for the day, and I hope you're enjoying. Do share the videos and do give your comments, valuable comments. That's all from my side for the day. Bye bye and take care.